Hello students, this is second part of the nutrition PowerPoint lecture, and last time we left at slide 13, so let's go to slide 14. Now this is again a review of your critical thinking. When you have to do nutritional assessment of a patient, you apply all the critical thinking basics, when you are taking care of this patient. You will go through the same nursing process, gathering data, subjective, objective, uh, and then, planning how you'll help this patient, how you'll take action. So the critical thinking is very important in, uh, as regard to the nutritional assessment of a patient. Your knowledge will include all the nutritional principles you have learned, and that's what we are doing right now. All Any basic or general idea you have about the how nutrition affects the patient's disease status, or it prevents making any disease more complicated. Also your own personal experience and your nursing school experience, and also how uh, because nutrition also means how the patient, um, you know what like how much patient is perseverant or disciplined to apply this diet in his life. And the personal and clinical experience can be, I believe, can be both of you and the patient, because some patients have their own perception about nutrition, and the change for them is a big thing, and it's you as a nurse who can assess that and then educate them accordingly. Standards are usually, what nutritionists, they decide, on a national level, uh, that what kind of diet can be the balanced diet or adequate diet for people. Now, if I would like you to be aware of the USDA's My Plate, because that is the most common dietary guidelines. Now, there is a Healthy People 2022 for maintaining patients' nutritional status. Uh, if I have to test you, I would test you on My Plate. Okay, and let's go to the next slide. Uh, Therapeutic diet. I'm not sure if you did a little bit of this in your 211, but a definition of therapeutic diet is a meal plan that controls the intake of certain foods or nutrients. It is part of the treatment of a medical condition and are normally prescribed by a physician and planned by a dietitian. So, registered dietitian, she doesn't have that power to order straight away a diet for a patient. It has to be prescribed by a doctor, and then it is in consultation with a dietitian, and then dietitian plans a particular diet. So if the dietitian says, to Dr. Smith, I think this patient should go on a low sodium diet, so she can recommend, and then doctor will write low sodium diet for Mr. Smith, and then registered dietitian will plan how low sodium diet will be applied to patients' meals, on the floor. So this is very important to know. So we need registered dietitian for consultation, and she plans the meals, but you know the the main prescribing of a diet is done by the doctor. Therapeutic diet is usually a modification of a regular diet. It is modified or tailored to fit the nutrition needs of a particular person. It can be either for patient recovering from illness or prevention of disease or management of any disease. And also usually you see these diet changes when patient is coming from surgery. Okay, and that time the patient's GI system has gone little slow, or peristalsis have been a little bit slow, and that time the doctor makes sure that the food is introduced back into the GI system, in a slow and less intense way. Let's go to the next slide. Next slide is why therapeutic diet order is ordered. And it is ordered to maintain nutritional status, to restore nutritional status, restore nutritional status, like, somebody is underweight or overweight, and or to correct nutritional status. So to restore nutritional status or correct nutritional status, I think it's more or less the same concept. To decrease calories for weight control, to provide extra calories for weight gain. Now, to decrease calories for weight control and to provide extra calories for weight gain, this case also the similar concept as to maintain nutritional status. To balance amounts of carbohydrates, fat, and protein for control of diabetes. To provide a greater amount of a nutrient such as protein, and to decrease the amount of a nutrient such as sodium. And on the floor, a lot of protein will be added um, for patients usually who are dealing with skin integrity issues, for wounds, etc. Unless it is not contraindicated for that patient, but usually for wounds, etc., for better healing of skin, a protein rich diet is encouraged. To decrease the amount of a nutrient such as sodium, and sodium is for high blood pressure patients, you know, patients suffering from kidney diseases. And it can also, the therapeutic diet can also be ordered to exclude foods due to allergies or food intolerance. Let's go to next slide. Therapeutic diet modification. Now, when in the earlier slide, in the earlier slide, this slide, we said, what are the causes, and the reasons, why somebody would need a therapeutic diet. Now, in this slide, I'm saying how therapeutic diet modification can be done. So there is food, what changes it can be done with the food so the patient's nutritional status can be maintained. So at first change which can be done to the food is for in texture. So texture means how it feels to the mouth, okay, how it feels when we take the food in. So texture, like we take foods which are solid, which takes food, which are little soft. We take food which are little. Sometimes we take food which are little kind of pureed. So texture is to do with how it feels inside your mouth. Like how you touch the food and how it feels on your on your fingers. So if you touch the food and soft, pureed, so that is texture. um, Another change which can be done to the food is for its nutritional value. So what, for a certain patient, doctor wants that this patient should be given high fat diet because there is a lot of malnutrition, or underweight has happened. A lot of weight loss has happened. For allergies, people are allergic to a lot of food items, and usually, mostly the common allergies are milk, soy, and we'll talk about this in detail in the other slides. Now, food changes can also happen if somebody is intolerant to a certain food item, like if they eat this particular item, they start vomiting, they are nauseous, they're not able to tolerate it. So Now, uh, the changes can also be made for allergy. Like I said earlier, for allergies. Now, a difference between allergies and food intolerance is very, very important, because food intolerance is like, uh, the GI system is not accepting it, that this food, I don't like this food. Allergy is that it can have some really uh, dangerous effect on the body. It can, so it's very important. Somebody says, I am allergic to food. I'm allergic to orange. So you ask the patient, what happens when you have allergy to orange? What happens to your body? Like, do you develop rashes, or your face swells, or you have, your voice becomes hoarse, or you have problem speaking, or you have problem breathing. So it's very important to know what kind of allergic reaction this patient has from this particular food item, orange. So food intolerance is like, you know example, I can say, there is a certain kind of butter I cannot have. If I have that kind of butter, I'll start vomiting. So this is what food intolerance is. Let's go to the next slide. Now, nutrient modifications can be done as nutrient modifications. That means how a certain nutrient in a food can be changed according to the prescribed diet order. So they can, example can be no concentrated sweets diet, diabetic diet, no added salt diet, low sodium diet, low fat diet, or low cholesterol diet, high fiber diet, renal diet. We will discuss this in detail in the further slides. Okay. Now let's go to the next slide. Texture modification, mechanical soft and puree diet. So mechanical soft diet and puree diet may have all the nutrition, but the texture is different. So that's why they're called texture modified diet. Then you have food allergy or food intolerance change diets. So and we will touch, I will explain you more later. So tube feedings, that is liquid tube feedings in place of meals, and then liquid tube feedings in addition to meals. Then apart from all this, in the next slide, there is something called additional feedings. Now, in additional to the already prescribed meal, sometimes extra nutrition is added to enhance patient's nutrition, to enhance patient's nutritional status, and it can be supplements, nourishments, or snacks. So sometimes they have HS snacks, like bedtime snacks, ordered as a snack, food, or beverage item to be given at the hour of sleep. Sometimes just for nourishment, um, again, any snack, food, or you know a beverage item can be given between meals, mid morning or mid afternoon. Like, when it's like these patients are allowed to have these snacks between meals, so they can have snacks between breakfast, lunch, and dinner. Supplements are usually ordered as liquid nutritional shakes once, something like Ensure. Maybe it can be once a day, twice a day, or three times a day, and it can be given with meals or between meals. So with patient's food tray, you can see Ensure is also coming. So that's part of additional feeding. Let's go to the next slide. I just want to drink some water. Now, therapeutic diets usually ordered for patients are these kinds, which you see on this slide: clear liquid diet, full liquid diet, no concentrated sweets diet, diabetic diet, no added salt diet, low sodium diet, and low fat or low cholesterol diet. I know, based on your previous experience, you have some knowledge about these diets, but let's understand it from point of view of floor, nursing floor. So when you say clear liquid diet, just remember this, um, that clear liquid diet is something, it includes a food items from which you can see through, okay, and it will leave minimum residue in the body. So like when clear, like just after surgery, just after surgery, um, usually doctor orders clear liquid diet, and they might be providing nutrition to the patient, but that time this diet will not make enough residue at the end of our digestive system, so we don't take out much poop, much, not many, not bowel movement, not a lot of bowel movement happening, because at that time a kind of our tummy is kind of sleeping, the GI system is just waking, it's kind of trying to wake up after the surgery. At that time we cannot force very hard solid food mm, in the GI system. And that time clear liquid diet, if we give a food items which are see through and they don't produce much residue, then the patient will be able to have the nutrition, as well as he'll be able to have a low residue, or just like almost negligent residue diet. So, and examples of these are juices without pulp. So, if a juice has pulp, it's not clear liquid diet. Chicken broth, any kind of broth, jello. Usually on the floors, they have jello's broth under clear liquid diet. And this is also, the clear liquid diet is also the first step to restarting oral feeding after surgery, or if there was any abdominal procedure. It can also be used for fluids and electrolyte replacement in people with severe diarrhea. So if somebody has diarrhea, the patient is going weak, but the GI system needs some rest, so it cannot have that regular peristalsis, cannot have that aggressive regular peristalsis. So that time this kind of diet is also used for fluid and electrolyte replacement in people with severe diarrhea. Now, clear liquid diet should not be used for an extended period of time, as it does not provide enough calories and nutrients. So that's very important for you to know. It cannot be done for a very long time, the clear liquid diet, because it does not provide enough calorie and nutrients. Full liquid diet includes fluids that are creamy. So all fluids that are creamy. Some examples of food allowed are ice cream, pudding, custard, strained cream soups, and juices with pulp, and pudding. Now, when I say strained cream soups, the strained cream soup is something which you can understand better if you can look at the image, or you can research on this. So I would like you to research on this. What does the strained mean? Okay, strained cream soup, because NCLEX many times give food items under this, and the NCLEX uses this word strained, STRANIED, strained cream soups, and also juices with pulp. And so usually full liquid diet is used as the second step to restarting oral feeding once clear liquids are tolerated by the patient. It's used for people who cannot tolerate a mechanical sour diet and should not be used for extended periods. So just like clear liquid, full liquid diet also should not be used for extended period. There is sometimes called no concentrated sweets diet. So if there is a diabetic person, and and he's on a portion control diet, which is like or portion control diet as decided by American Diabetic Association, and you know that it's something called exchange list for meal planning. um, I think San Mateo Medical Center, they have a very good diabetic diet book for patients, and I don't know if it is there on their acute floor, on their like 2A and 2B, the med surg floor, because I saw this in ICU when I took my students to ICU in spring, and they have a very good book on um, exchange exchange list for meal planning for patients. So yeah, so anytime if there are diabetic patients, their calories are counted, their portion control is done, and but when these diabetic patients have their weight and blood sugar under control, then they can go back to the regular food, with where there's not much of counting of calories are being done, or not much of carbohydrate, protein, and fat calculation are being done. So when they go back to regular food, when their weight and blood sugar are under control, then one thing doctor can say is that okay, so you can have regular food, but there should not be any addition of sugar. So no concentrated sweet diet, like no cakes, no donuts. So those are examples of concentrated sweets diets. So now again is diabetic diet, and I just explained that diabetic diet is a calorie control diet. These diets control, actually diabetic diet is something which doctors also prescribe for people who are overweight or obese. So because these diets control calories, carbohydrates, protein, and fat intake, and they do it in balanced amounts to meet nutritional needs of patient. And also these um, calorie control diet will also control blood sugar and also control patient's weight. Now the portion control is usually done at meal times, and they have this word exchange list for meal planning. Um, Most commonly used calorie levels for these ADA diets are like 1200 calories per day, 1200 calories per meal, 1500, 1800, or 2000, and they will do it. They will tell the patient that this is the USDA's my food plate, and based on this USDA's my food plate, and based on our recommendation of American Diabetic Association, we believe that you should have so many calories in a day. Now let's see how you get these calories from this much of carbohydrate, this much of protein, and this much of fat. So this is how the diabetic diet is planned on the floor for patients. No added salt diet. No added salt diet. The difference between no added salt diet and low sodium diet is that no added. Now, one thing which uh, the one thing which I did, when I got married was because I had I didn't have that habit of adding salt to my food, so I was never fond of salt shaker. So one thing which I did when I got married was I threw the salt shaker from my house, and there was no salt packet, nothing. So my husband went through a big change because he was used to adding salt to his food, and it really helped him, uh, with his blood pressure. So, so no added salt diet is a regular diet with no salt, like no salt shaker on the tray or no salt packet on the tray. Food is seasoned as regular food. So, like, the regular seasoning which you do is there, but you don't add any salt on it. Low sodium diet is maybe called a 2 gram sodium diet. So, throughout a day, only 2 grams of sodium should be encouraged. Limit salts and salty foods such as bacon, sausage, cured meats, canned soups, salty seasonings, pickles, pickles, all salted crackers. And it can also be used for people who may be holding water or who have high blood pressure, high disease, heart disease, liver disease, or going towards the first stages of kidney disease. So low sodium diet is is limiting absolutely the sodiums in these. When they have low sodium diets, they should be looking at all the food items they buy from grocery stores, looking at what is the sodium content of this, and usually I think when in the process soups cans, those Campbell cans in grocery stores, they have very high percentage of sodium. So if my kids have a desire to have soups, I usually prefer making it at home rather than buying it from the grocery store. Though I hate cooking, I don't like much of cooking, but I still do it. Bare minimum necessary for my kids. And I try as much as possible not to get the processed food from outside and have as much as homemade food, because homemade food will be still much less in sodium than the outside food. Low fat and low cholesterol diet is used to reduce fat levels or treat medical conditions that interfere with how the body uses fat, such as diseases of the liver, gallbladder, or pancreas. And it usually says that you limit fat up to 50 grams of no more than 30% calories derived from fat. As low fat is low in total fat and also in saturated fats, and it aims at approximately 250 to 300 milligram of cholesterol. So let's go to the next slide. High fiber diet. High fiber diet is usually prescribed by the doctor in the prevention or treatment of a number of GI, cardiovascular, and metabolic diseases. Uh, and increased fiber will come from a variety of sources, including vegetables, whole breads, cereals, fruits, etc. So, and then the renal diet is for kidney people, renal or kidney disease patients, and it is individualized depending on if the person is on dialysis or not. The diet restricts. Now, in renal diet, like earlier, see when we were talking about low sodium, it was only low sodium. And low sodium diet can be part of a diet for a patient who's suffering from kidney diseases, such as a CKD or ARF. CKD is chronic kidney disease. ARF is acute renal failure. So diet plan is individualized depending on if the person is on dialysis or not. For if the patient is on dialysis, they will still do the same uh, concept of restricting some, you know, some minerals in the body as they will do it for a chronic kidney disease patient, but there'll be some changes. Mostly the purpose of the renal diet is to restrict sodium, potassium, fluid, and protein at the dietitian recommended specified levels. And for renal diet, lab work is followed very closely. So the doctor wants to know that if there is restriction done on a diet, how is showing in the lab. So they will look at the patient's sodium, potassium level in the lab. Um, Mechanically altered um, or soft diet. Um, so students who are going with me on Neurofloor, the fifth floor, Neurofloor in Kaiser Redwood City, we have many patients on stroke. And I think some of you might be having stroke patients on your regular med-surg floors too. And also in Kaiser, they have more stroke patients because I think it has become certified as like comprehensive stroke center also. So more stroke patients you can see in Kaiser Redwood City. Now, almost all of these patients, if they have some swallowing difficulty, they all are ordered mechanically altered or soft diet. And this is usually ordered for people who have problems with chewing and swallowing. And there can be another reasons too why patient can be ordered mechanically altered or soft diet. But I particularly picked stroke because this is the most common reason when it is ordered mechanically altered or soft diet. Um, Now it changes the consistency of the regular diet to a softer structure. So when I'm talking about mechanically altered or soft diet, whenever the word texture is used, it means that the food consistency is being changed. So the in mechanically soft diet foods, um, a regular diet's consistency is changed to a softer texture, and it includes chopped or ground meats as well as chopped or ground raw fruits and vegetables. It's for people with also can also be for people with poor dental conditions, missing teeth, no teeth, or a condition known as dysphagia. Dysphagia, problem swallowing. Dysphagia is difficulty with swallowing. The last, no, there's some more. Puree diet. Puree diet is just making the food pureed by smooth liquid by uh, having it a consistency, giving it a consistency of smooth liquid. And it is indicated for those with wired jaws, extremely poor dentition in which chewing is inadequate. Often it is thinned down so it can pass through a straw. So a puree diet can be taken through a straw, and it is for people with, and that can also be for people with chewing swallowing problem. Um, Now foods, when there are like five food items on the plate, they're all not pureed and then all pureed together and given to the patient. No. So if there are five food items on patient's plate, all of them separately will be pureed and put on the plate. For pureed food item, one should avoid nuts, seeds, raw vegetables, and raw fruits. Uh, it's nutritionally adequate when offering all food groups. And all these diets, there's one thing also attached with these diets. How about if patient is going on these diets home? So patient education, by the nurse is very important. And also sometimes when these patients go on these diets, there is also a registered dietitian. She will also do some patient education. Food allergy modifications. Now, food allergy is equivalent to, uh, you know, an abnormal immune response by the body to an otherwise harmless food. So maybe, I'm not allergic to milk, but maybe some of you may be allergic to milk. I'm not allergic to egg, but some patients can be allergic to egg. So I'm not allergic to peanuts, but some patients are allergic to peanuts, or some of you might be allergic to peanuts. So the allergy is something which has clear connection with body's immune response, and the immune response will be abnormal. So when there is an abnormal immune response by taking any food items, it's important for the nurse to know. Um, then we can make appropriate substitutions to ensure that the meal is adequate. And the foods items with allergies are strictly removed from the patient's diet. And as I said, the most common food allergies are milk, egg, soy, wheat, peanuts, tree nuts, fish, and shellfish. Uh, if if a patient wants a gluten-free diet, then it would include the elimination of wheat, rye, and barley. So instead of wheat, rye, and barley, for a gluten-free diet, we can have patients can have potatoes, corns, and rice products. Okay. Food intolerance. The most common food intolerance is intolerance to lactose, which is milk sugar, because of a decreased amount of an enzyme in the body. Other common types of food intolerance include adverse reactions to certain products added to food to enhance their taste, color, or protect against bacterial growth. So, common symptoms involving food intolerances are vomiting, diarrhea, abdominal pain, and headache. Oh, headache is very important. I have experienced this. So, what happened is I just remember something. We were flying, I think we were flying from Jersey to uh, New Jersey to, no, we were flying from LA to New Jersey via Jet Airways, Los Angeles, New Jersey via Jet Airways. And now Jet Airways, um, local flights, some of them are very good. JetBlue, I think JetBlue Airways, and they had a very good meal plan. And we had been so busy, packing for this trip of ours that we had not enough to eat. We were just running around, and the plane was also very early in morning. And when we reached in the flight, they asked, menu, you want this, you want that, and my kids, they were like, oh yes, mommy, I want this, I want that. And my husband, he ordered. And after a while, my uh, I think my daughter, she started feeling, she said, mommy, I'm having tummy ache, I'm having cramping in my tummy and everything, and then whatever, I think they had a certain kind of cheese which my daughter never had, and she started, then she vomited. And can you imagine, just starting a trip and your child vomited? That was a clear indication for me. Next time when I'm buying food on flight, I will look at everything, I will analyze it, and then give it to my kids. So yes, food intolerance can, it's not important that can only happen to patients, it can happen to anybody. And it does include vomiting, diarrhea, abdominal pain, and headaches. Tube feedings are used for people who cannot take adequate food or fluids by mouth. All or parts of nutritional needs are met through tube feedings. Some people may receive food by mouth if they can swallow safely and are working to be weaned off the tube feeding. Okay, so tube feedings, it's not important that tube feeding is mm, uh, tube feedings is sometimes um, used also uh, as a, no, what I'm trying to say is that tube feeding is sometimes used for people who cannot take adequate food or fluids by mouth. So it doesn't mean that they cannot take adequate fluid or foods by mouth at all. They can take some food or fluids by mouth, but they're not taking it adequate, and the nutritional needs are not being met. So some page doctor can say we are doing tube feedings, and some people may receive food by mouth if they can swallow safely and they're working to be weaned off the tube feedings. Okay, so that's how it is. And especially sometimes they do it for anorexic patients, 16-year-old girl dieting, totally, malnutrition, absolutely low weight, and that time, she cannot, she didn't take adequate nutrition, not, she didn't have adequate balanced diet. It can affect her body's homeostasis. That time doctor can decide we need to do some tube feedings, and this girl can have tube feeding for like maybe two days or 3 days, and then after that she can be weaned off the tube feedings, and she can be encouraged to start with the good balanced, diet, food taking by mouth. Okay, so let's go to the next slide. Now, nutritional screening tools. Now, nursing process first is assessment. So, how we'll do assessment as regard to nutrition. So, nutritional screening is part of your initial assessment of a patient, and the screening is a quick method of identifying malnutrition or risk for malnutrition. A single objective measure alone will not predict that the patient is at nutritional risk. So a lot of important, you know, uh, multiple parameters are there to decide whether the patient is going to have a nutritional risk or not. Certain nutritional risk factors we have to take into account, such as unintentional weight loss, the presence of a modified diet, or the presence of uh, you know any triggers, nutritional triggers in the body. Now, the nutritional scale screening tools include objective is something which you and me can verify together. We can, so like height, weight change, primary diagnosis, comorbidities. And then outpatient screening tool is something called subjective global assessment. um, in the outpatient test setting, and this is used in mostly in outpatient setting, subjective global assessment, which is known as SGA, which is a validated clinical method that uses the patient's history, weight, and physical assessment data to evaluate nutritional status. So this global assess SGA will ask some questions about patient's history, their diet pattern, how their weight and weight and other head to toe physical assessment to evaluate nutritional status. The SGA is a simple, inexpensive technique that predicts nutrition related complications. um, in your book, it has in your book, Potter and Perry, it has given a detailed description of subjective global assessment tool. Uh, what are the components of it. And if I have to ask you, I will be asking you that, do you know what is subjective global assessment? So I won't go much deep on this. Nutritional assessment, we're continuing with that. We'll want to know the patient's diet history and medication history. Uh, Now, if we see that the patient is at risk, we can refer this patient always to a registered dietitian for nutritional assessment. Now, nutritional assessment is different from nutritional screening. The registered dietitian, she completes a nutritional assessment, which includes an in-depth exploration of uh, medical history, dietary history, physical examination, anthropometric measurements, and lab data. So, nutritional assessment is in-depth. In-depth nutritional is a okay. So now, as I was saying, nutritional assessment is different from nutritional screening. The registered dietitian, she completes a nutritional assessment which includes an in-depth exploration of medical history, patient's medical history, his dietary history, the patient's physical examination, his height and weight measurements, and lab data. So that is the nutritional assessment. What we as nurses do on floor is mostly nutritional screening based on certain tools, or more of a focused kind of, you know, uh, assess focused kind of information we get from patient. Um, yeah, we ask patient about what kind of food they prefer, their allergies, and if they have having any digestive problems. And also knowing which medication your patients take is important when meeting their nutritional needs. Prescribed and over-the-counter medications have the potential for drug nutrient interactions. So consultation with a um, sometimes you can consult a pharmacist, that to determine the specific risk for nutrient drug interaction for your patients. So food, getting knowledge about their food is very important. So we can ask them, what type of diet you want, vegetarian, non-vegetarian, and then what do you take any mm, you know over the counter medications. Then if over the counter medications, they can be, as we have done in the earlier lecture, they can easily react with some drug items or some food items. So consultation with a pharmacist, if you're not sure that a patient eats this and will it be reacting with the medication given on the floor, so you can ask the pharmacy about that. Also, very a lot of age-related factors also affect the patient's nutritional status. The presence of chronic illness, anorexia, slowed digestion, and peristalsis, decreased physical and cognitive function, ability to feed self, medication side effects, loss of dentition, and reduced saliva production may all contribute to development of malnutrition. So there is a small mini nutritional assessment exam in your assessment exam in your book, and it's a chart in your book and Potter Perry book, and it was developed as a nutritional screening tool for the older adult population. And this 18 item tool has two sections: screening and assessment. The screening section contains 6 questions related to decline in food intake, weight loss, mobility, stress, and BMI. The health, the health, maybe the the doctor or the healthcare provider or the nurse practitioner, she completes the assessment portion if the patient scores 11 or less on this mini nutrition assessment uh, tool. So I want you to look at the screening portion of this mini nutritional assessment. Um, It's in your Porter Perry book under the chapter on nutrition, mini nutritional assessment for older adults. And why I want you to do it, because this course uh, is heavily directed towards gerontology and of course as well as towards medications. Okay. So I want you to review the mini nutritional assessment in your Potter and Perry test book to see the screening portion of the mini nutritional assessment. Okay. Let's go to the next slide. Now, assess any patient who's at risk for nutritional problems and they which is interfering with his daily life, or he cannot have adequate he cannot have adequate nutrition. Uh, Now, assessment, of course, includes physical examination, anthropometries like height and weight, lab values. Also, look if the patient has problem with swallowing. So, dysphagia screening. We do dysphagia screening also with stroke patients. So, where you have to do some mini exam at the bedside. You would ask patient to take a sip of little bit of water and see if they have problem swallowing, or take a little bit of ice chips and see if they can swallow. So that's something which nurses do as a part of their assessment. And also, what is the patient expectations about their diet, about their diet, about their food habits, or how their disease process or their problem for which they are on the floor, how it will interfere with their nutrition, how nutrition will help it, and how they need to modify their nutrition to get better. Um, now, now, there is no single lab or any test which is a diagnostic for malnutrition. Um, there are a lot of certain things we need to look at the patient in the patient's lab. It can be CBC, complete blood count. It can be patient's albumin. It can be its electrolytes, his glucose, his cholesterol, his triglycerides, his nitrogen, blood urea nitrogen level, which is and then so these are all the things which will assess to get a picture of the malnutrition. So there is not certain one test which will say, oh, we do this test and we know patient has malnutrition. We have to look at a lot of lab values. Um, Now dysphagia, I think I talked about it a lot, but So it's just a patient has difficulty swallowing, and it might be due to a condition where a damage to facial muscles or nerves or has occurred, and patient cannot use his facial muscles to or his nerves have been damaged, so he cannot swallow. Uh, if the patient has dysphagia, he will show certain signs. He will cough. He will have change in voice tone or quality after swallowing. He will have abnormal movements of the mouth, tongue, or lips, and his speech will be uncoordinated. Okay. Uh, Now, the bedside tool which I um, earlier mentioned, it's called bedside swallowing assessment for dysphagia. So um, if you can research on your floors, you'll be able to see how nurses do this bedside screening, bedside swallowing screening for the patients who might be expected to have you know dysphagia because due to disease process or due to a recent diagnosis of stroke or something, their facial muscles or nerves have been affected. Um, let's go to the next slide. So we were talking about the when we started this PowerPoint, we were talking about Mrs. Gonzalez, a 65-year-old woman, and who had come with the stroke attack. And when assessment findings were that Mrs. Gonzalez, she starts to cough when she tries to drink water. Mrs. Gonzalez is unable to swallow and aspirate pills and thicken liquid. Lung sounds are clear, respirations are regular at 12 per minute. She has no dyspnea. Dyspnea means she has no shortness of breath. Oxygen saturation is 96% in room air. Enteral nutrition will begin at 60 ml per hour. Enteral nutrition, that is um, tube feeding, a feeding tube has been put inside her GI system, so and she'll be given nutrition through that instead of because she cannot take food through mouth, and it will begin at 60 ml per hour. Now, so based on the assessment findings, a nursing student, which we were studying earlier, Matt, he assessed Mrs. Gonzalez risk for aspiration. He also evaluated Mrs. Gonzalez swallowing ability. He monitored her respiratory status and he assessed her nutritional status. Now, what diagnosis you think it would be there for this patient? Um, if I'm a nursing student and I have to make nursing diagnosis for this patient, one of the diagnoses for this patient will be also risk for aspiration based on just the assessment data findings we just collected. So let's go to the next slide. These are some of the common nursing diagnoses as related to nutrition. Following nursing assessment, there are some defining characteristics which can help a nurse determine whether there can be an actual or potential nutritional problem in future for the patient. Um, and a change happens when the body does not ingest a nutrient in sufficient quantity, when it poorly digests or does not completely absorb nutrients, or when total daily caloric needs are deficient or they are more or excessive. Um, Now, some of the nursing diagnosis can be risk for aspiration, diarrhea, adult failure to thrive. When they say adult failure to thrive, it means that patient cannot, because of the nutritional problems, patient cannot uh, cannot live a regular daily life. Just like you and me, he has some problem surviving. You know, with his body's imbalanced homeostasis. Uh, Deficient knowledge. Most of the patients, I think most of the diabetic patients I've seen, they have this nursing diagnosis of deficient knowledge. Imbalanced nutrition, less than body requirements, can be easily for the patient who's suffering from anorexia. Imbalanced nutrition, more than body requirements, can be easily for a patient who has morbidly obese or obese. Readiness for enhanced nutrition is something where a patient uh, doesn't understand how calcium should be added to his or her diet, and then now she understood how calcium should be part of her diet and she's ready for this new change. So that's called readiness for enhanced nutrition. Risk for imbalanced nutrition more than body requirements. uh, Risk for now imbalanced nutrition more than body requirements, the earlier one is for person who is actually obese, morbidly obese. Example, morbid. Now, risk for imbalanced nutrition more than body requirements can be for somebody who's right now is on the border of becoming overweight or obese. And so, for that, you can say risk for imbalanced nutrition more than body requirements. Impaired swallowing, feeding self care deficit. So, these are some of the common diagnoses for as related to nutrition problems. So yes, we did for Mrs. Gonzalez. Diagnosis rest for aspiration. Goals will be Mrs. Gonzalez will receive adequate nutrients through the tube feeding without aspiration by the time of discharge. Mrs. Gonzalez will regain swallowing ability from speech therapy by the time of discharge. Uh, and what can be some of the expected outcomes for this patient? Some of the expected outcomes for this patient can be that Mrs. Gonzalez weight at discharge will be within 2 pounds of admission weight. Mrs. Gonzalez will not show signs of aspiration before discharge. Mrs. Gonzalez, albumin and pre-albumin levels will remain normal before discharge. His progress will he will that Mrs. Gonzalez will she will progress to a oral diet before discharge to a rehab care facility. Let's go to the next slide. So, again, what I said earlier, goals and outcomes. You will set priorities, anticipate what is most important to help your patient achieve good nutrition. And the part of nutrition will not only be the patient but also the patient's family members. We can also involve professionals, dietitians, nutritional support, or clinical nurse specialists in the hospital, or pharmacists, or even doctors. So everybody can help Mrs. Gonzalez to um, achieve the goal, of improving nutritional status. Health nursing process implementation. So now we are saying we are coming to the step of implementation in nursing process. Health promotion is a very important part of nursing life, and we will educate patients and family caregivers about balanced nutrition and to assist them in obtaining resources to eat high quality meals. Meal planning, education, weight loss plans, food safety, these are all part of nursing health promotion. uh, Now, healthcare professionals like doctors, nurses, dietitians, they should not only be aware of factors related to food safety, but also should provide patient education to reduce risk for foodborne illnesses. So now let's go to the next slide. Acute care. So this is particularly talking about the hospitals. It's the role of the nurse is to provide a comfortable environment, assist patients with feeding, especially the dysphagia patients, if they have problems swallowing, and also patients with disabilities, if they cannot use your hands. So, and our job is to provide an environment which is conducive to eating. Make sure the patient, does hand hygiene, and if you're feeding, you're doing mouth care, or patient is at pain. Sometimes patient is at pain, he's experiencing pain, and you're saying, oh, the meal time is here. I want you to have your breakfast. I want you to have your lunch, but patient is in pain. Do you think you and me would be able to eat a meal properly if we are having pain? So that if a, then that is the first thing we need to take care of. So we will give patient analgesics, or you know or antiemetics. Antiemetics are something which will prevent patients vomiting and nausea, so before having meal. Now, if a patient says, I don't want this meal, then you make every effort to replace it with a suitable alternative. So you can say, you can investigate what part of that meal he doesn't like, or if any suitable substitute can be done for that meal. And if patient says, I don't want this meal at all, then you educate him more, how this meal is important for him, how nutrition is important for even medications to work, and also body to heal better. um, so this is all part of nurse's role. So many times patient says, I don't want to eat, and the tray goes away. Whenever patient refuses anything, the first priority you as a nurse is to educate them that how nutrition is important in their life for their hospital stay, and how it will help them to get better. Next slide. So this is interventions for those unable to meet nutritional needs orally. So somebody cannot take food through mouth, and there is an enteral tube feeding. Now, whenever I use the word enteral, when I use the word enteral, when I use the word enteral, so I'm saying it many times. Enteral nutrition refers to administration of nutrients and fluid into the stomach or intestinal tract via a feeding tube. And the NG feedings are introduced into the body through nose and into the stomach. And you all have gone through this skills lab. Um, Now, there is something called nasointestinal feeding. Now, nasointestinal feedings are delivered through a feeding tube inserted through the nose and into the small intestine, which is duodenum or jejunum. So, if there is a tube going in the duodenum or jejunum, it means it's going towards the small intestine. And in one of my student groups, they were not even aware of that. So, I want you to be aware of what parts organs belong to small intestine and what structures belong to large intestine. When patients have nasopharyngeal obstructions or are not candidates for nasally placed tubes, or when the need for enteral nutrition is anticipated to be longer than several weeks, feeding tubes may be inserted directly into the stomach. That is, then those some such as gastrostomy tube, or jejunostomy tube. Okay, so when they cannot put it through nose, then a surgeon doctor, the GI surgeon, can put the tube directly into the stomach. A variety of enteral feeding formulas are available to meet patient needs when a patient cannot safely swallow food or take adequate amounts of food orally but can digest and absorb nutrients. A small bore feeding tube is placed nasally into the stomach or small intestine. Um, when making the decision regarding enteral access, the healthcare provider uh, considers that considers the patient's rate of gastric emptying on GI anatomy, risk for reflux and aspiration, and the other factors. Now, enteral feedings should be correctly connected to an enteral feeding tube. So, the gold standard for determining tube location is radiographic confirmation. Now, this is something which NCLEX tests you a lot on. Now, so suppose whenever there is a tube going inside the patient's GI, and patient, either you have done through NG tube feeding, or GI surgeon has put this tube inside patient's, and in the patient's GI system. Before starting any feeding, the gold standard, it's called the national gold standard, which has been done by through research. The national gold standards for determining tube location inside the patient's body for this purpose is radiographic confirmation. Radiographic confirmation is what? X-ray. So X-ray needs to be done. Unless the X-ray reports come, you cannot start the feeding. Never do this. it's a big error. Now, assessing the color and pH of gastric aspirate for ongoing monitoring of tube location has been shown to be effective and less costly. So, anytime tube goes inside, X-ray needs to be done to see whether the tube is placed appropriately in the anatomical part of the body where it's supposed to be, and then the feeding starts. Later, when the patient already has tube in the body, and then that time the nurse wants to aspirate to see that the tube is in its proper place, that's okay. But first time, X-ray is important, and you have to document it if you put the NG. Now, so um, let's go to this. So this is also this. The picture shows the surgically inserted tube feeding. So let's go to the next. Uh, oh, this is now. Let me see this. Now, if there is a G tube, which is usually called a gastroscopy tube, they are just when you see a G tube, just remember these G tubes can be done for feeding for longer period of time. So, and they have more freedom for patients, so they can be done for longer term feeding. Um, okay, so G tube, and usually that's why you see G tube mostly in long term care. Okay, G tube. Let's go to the next slide. Now, again, we are talking again about the different kind of enteral tube feeding, which is jejunostomy tubes and tube feedings, and also displacement. When patients have a late gastric emptying, or have had some kind of surgery, gastric resection or other surgery in the upper GI tract, such as pancreatectomy, or then a jejunostomy tube or J tube may be inserted to deliver nutrition. So when patients have delayed gastric emptying, or they have had gastric resection or other surgery in the upper GI tract, such as pancreatectomy, then a jejunostomy tube or J tube may be inserted to deliver nutrition. Um, Now, the feedings which are done via J tube, they are usually delivered even more slowly because the jejunum lacks the storage and regulated emptying capacity of the stomach. So, what structure the tube is in will decide how the gastric emptying is happening. So, feedings delivered via J tube or jejunostomy tube are usually delivered more slowly, over a period of hours, like overnight, because the jejunum lacks the storage and regulated emptying capacity of the stomach. Um, Now, there is something called gastrojejunostomy. Now, gastrojejunostomy tubes are tubes that have access to both the stomach and the small intestine. And the gastric port may be used for decompression of accumulated stomach content while feeding a patient. So, and which you need to know which port is gastric and which port is jejunal. So, if you have to do a decompression of the accumulated stomach content, then you will be using a gastric port. Okay. Um, so the picture shows you one. So what port needs to be done for gastric decompression, should be used for decompression, is important. So if you have patients which have anytime have tubes other than NG tube, which you are not aware of, so always get some knowledge, research before uh, doing anything with these tubes. It is important to monitor and uh, monitor these tubes. Now, most important is that the site of these tubes insertions, they are heavily prone to infections. So proper care is important. Properly taping it to, to the abdomen, or is very important. Anytime a tube is displaced, it can lead to infusion of fluid into the peritoneal space. So you have research what is peritoneal space. So if these tubes, these feeding tubes, they get displaced, they can lead to infusion of fluid into the peritoneal space, and this can lead to very serious, dangerous complications. So when you have these tubes and you feel that you don't know what kind of tube it is, research before doing anything with this tube. One more important thing is, many times you'll go on float, you'll see around these tubes, many times there is a lot of, you know, a lot of dirt, like dirty. The site is dirty, and some of the nurses have not cleaned it. So you clean it, okay, and and then take advice in, from what port I can aspirate and check, how I can, give medications through this tube, and what are the hospital's policies regarding this tube, or what is the facility policy regarding this tube. Okay. um, I have seen, yes, no, I don't want to go to that. It's your choice. It's your choice whether you want to pick good practice or bad practice. Let's go to the slides. Providing parenteral nutrition. We did talk about a little bit in class about this. Parenteral nutrition has increased risk of infection. Solution is formulated to each patient's needs. Need for parenteral nutrition is evaluated daily, and there is central parenteral nutrition and peripheral parenteral nutrition. Now, I did tell you in class about TPN, isn't it? TPN is total parenteral nutrition. So now we are coming out of that enteral nutrition. So this here now, the doctor is not using digestive system for giving nutrition to the body. It is using something else. It is using patient's veins, IV, to give nutrition to the body. And TPN stands for total parenteral nutrition, while PPN, there is, apart from TPN, there is something called PPN, PPN, which is partial parenteral nutrition. And total means the patient receives no other form of nutrition, while partial means they are receiving another source of nutrition, probably via feeding tube. So if they were receiving TPN, there would be more nutrients in the mixture than PPN, because the doctor will take into account the nutrients from the tube feedings as well. Okay, so TPN is like all nutrition to body through this total parenteral nutrition. PPN means partial parenteral nutrition. That means board patient might be getting nutrition uh, through a feeding tube, as well as through this partial parenteral nutrition. So here the feeding tube is also being utilized, and also patient's vein are being utilized to give nutrition. If they were so now, if they were receiving TPN, which is total parenteral nutrition, there would be more nutrients in the mixture than peripheral parenteral nutrition, because for PPN, doctor knows that the patient is getting some nutrients through the feeding tube also. But for TPN, doctor knows that the only form of nutrition for this body is through that bag. So there'll be more nutrients in the TPN than as in PPN. Um, Now, as far as it's going to the central line and not a peripheral line, a central line is placed to end in the superior vena cava, which is, you all know, is the heart. A central line is placed to end in the superior vena cava, and the superior vena cava is a very large blood vessel with large amount of blood flow, so it can handle any caustic fluids being infused into it. A peripheral line is much smaller and it has a lot less volume throwing it through in any given time. So when caustic fluids are infused, it is very damaging to the vessel wall and can cause a lot of complications. So through a peripheral line, which is like a normal IV on the hand, which you have seen on the floors by now, if you give large amount of caustic fluids, because TPN will have a lot of caustic fluids, it will damage the peripheral line, can get damaged and can have more complications for body. The reason why TPN is caustic is because it contains a lot of particles, that is glucose, and it's several minerals and electrolytes. Scientifically speaking, the osmolarity is too high for a small vein to handle. So the osmolarity of that content in the bag of TPN is too high for a small vein or a peripheral vein to handle. Parenteral nutrition is the administration of a solution consisting of glucose, amino acids, minerals, electrolytes, and vitamins through a peripheral or central venous catheter. Okay, so I hope I made clear up the difference between TPN and PPN. Um, okay, now there is an increased risk for infection when administering parenteral nutrition because it requires intravascular access. When I say intravascular access, that means something to do with blood vessels. So it requires blood vessel access, and because of the high concentration of glucose in parenteral nutrition's risk of infection is very high. Now, not everybody will be on parenteral nutrition. There should be a clear evaluation done by the doctor, maybe with the dietitian or with somebody else or the patient's family member, and that we are now going to do some, parenteral nutrition on this patient. The goal is to move towards the use of GI tract for oral intake or enteral nutrition as soon as possible. So the patient is in a very high acuity disease state, and there is no way that he can take anything by utilizing his GI system. At that time, the doctor says we are going to do another parenteral nutrition. But the end goal will be using the GI tract for oral intake or going towards maybe the feeding tube or the enteral nutrition. There are two types of parenteral nutrition, central and peripheral, and now perhaps now parenteral nutrition, which uses a central line, is central PN, and it contains 10% dextrose or greater, so it gets 10% sugar in it, and it is administered through a central venous catheter. Then there is peripheral parenteral nutrition. It has solutions with osmolality greater than 900 milliliter osmomole, administered through peripheral lines. Now, in my life as an RN, I have seen mostly TPN being used, very less peripheral. So usually TPN is used. So I don't expect you to memorize the osmolality parameters, but I just know that peripheral PN will be having less caustic material in it as compared to TPN. Let's go. Providing parenteral, then uh, so this is just a repetition of what I said earlier. Initiating parenteral nutrition, it requires, a central venous catheter inserted into the superior vena cava via the subclavian vein or the jugular vein. The administration of PN can also be done through a peripherally inserted central catheter or a PICC line. Uh, a chest X-ray confirms the location of this, central line, and sometimes patients have long-term central lines, especially the cancer patients, and for that, those lines can be used for these nutritional purposes. Um, your part in patient care is preventing infection, maintaining the parenteral system. Parenteral system is that access which the patient has, preventing complications, meeting nutritional and fluid needs. So you have to know the ingredients of these parental nutrition, that how much glucose, how much potassium, how much vitamins are part of these bags. And then if the patient is going home on parental nutrition, then you have to do uh, if patient is going home on this nutrition, then you have to do proper support and education how it will be done at home. uh, so this is slide 38, and I will stop here because this is also becoming very big. So most probably the nutrition PowerPoint slide will have 3 parts. So I'm stopping here. Okay, so slide 38.